right, everyone. As I just said, welcome. My name is Ben Milner. I'm an exercise physiologist from Keyser in Brighton. And presenting with me today is Nicole Shue, exercise physiologist from Keyser in Melbourne. So before we get into the presentation, for those of you that aren't aware what an exercise physiologist is, so here at Keyser, we use exercise as therapy and as treatment to manage and treat any kind of chronic disease or chronic illness. How we differ to physiotherapists, for example, although there is a lot of common ground, but the physiotherapists are much more musculoskeletal and acute injury based, whereas we're much more chronic disease based. What we're going to cover today, we're going to start with looking at the structure of bone. We're going to talk about the prevalence and the risk factors of osteoporosis. We're going to talk about the fracture risk and introduce you to a term called the fracture cascade. We're going to go over how osteoporosis is diagnosed. Nicole will introduce you to a term called bone remodeling. And then we're going to look at what are some treatment options. So briefly touch on the medications and then dive into the exercise prescription. And then we'll finish off with what we're doing at Keyser. All right, so we're going to start here with looking at the structure of bone. So bones in the body have 5 primary functions. Number 1, they support the body, they keep us upright. Number 2, they help facilitate movement. All our ligaments and tendons and muscles attach to bone, so we need them in order to do any movement. They protect internal organs, so example is our rib cage around our heart and our lungs. They store minerals within them and produce red blood cells within the bone marrow. So if we're looking at a common bone, the picture of the bone there is a long bone, particularly found in your upper arm or in your thigh. This is sort of sliced in half so you can see the inside. We actually have 2 different types of bone within there. The first one is that thick bone you see around the outside. Now that's called our compact bone or our cortical bone. This type of bone is really beneficial in protecting against any form of bending or twisting forces on the body. And then inside that, you can see that spongy looking bone, which is referred to as spongy bone or called trabecular bone. And this protects against compressive forces and compressive loads. So the 2 forms of bone together work together to absorb force and prevent fracture or breaks within the bone.
So what happens to us over time? So generally speaking, as we age, we do lose fitness. So there's a deterioration commonly in your joints, so you get the wear and tear, but also we do lose a bit of muscle mass and bone health as well, bone density. We commonly lose flexibility, and we also become less active or physically active, generally speaking. So what this, statement here, depicts is after the age of 30 years old, adults start to lose about 3 to 8% of their muscle mass per decade. As we, reach 60 and above, unfortunately that decline is a lot faster or higher. So the good news is we can slow this process down through the use of, exercise and doing the most optimal program as well. But that's generally speaking, what will happen with everyone over time. So this next graph here actually represents specifically what happens with our bone density. So along the y-axis, so the one on the left, is your bone mass, and then along the x-axis here is the age in years. So we've got both females and males represented here with the different colours. So as you can see, over time, for both genders, we do reach what we call our peak bone mass at around about 30 years of age. Obviously, there's going to be a number of factors that may contribute to, the development of the bone growth, whether it's absorption of the calcium, etc. Then from about 30 years old, we do see a gradual decline in that bone mineral density, much the same as your muscles, etc. What we can see with the pink, so the females, there is a rapid decline here when menopause occurs. So for those who may experience maybe early menopause, you may find that your bone mineral density actually drops a lot steeper earlier, in your life. So that's just due to an imbalance within hormones, which unfortunately can lead to the development of osteopenia and osteoporosis. The great news is you can actually reverse this and again slow down the process through the right types of exercises, which we'll touch on down the track.
Okay, so what actually is osteoporosis? I've mentioned it a few times. The word osteoporosis literally means porous bone. So by the bone being more porous, it is then more brittle and unfortunately has an increased risk of fracture. The way we develop osteoporosis, as Nicole mentioned, is the gradual loss of your bone density over time. But it also can be caused by the loss of minerals such as calcium that aren't maybe being replaced as quickly as they should be, and over time can result in a reduction in bone density. And unfortunately, it's a silent condition, so there's no obvious symptoms for osteoporosis. You're not going to have back pain or get pain directly from the osteoporosis. You may have that from another musculoskeletal issue, but it's very challenging if you haven't had a scan before to know if you're going to have it or not. So that's why we do recommend having regular scans once you get over the age of 50, 55, especially as a female, because it can sneak up on you. So I'm just going to go back to another picture of bone here and just compare an osteoporotic bone to a apparently normal bone. If you look on the picture on the left, on the top bone there, you can see that nice thick cortical bone I mentioned before around the outside, and the spongy or trabecular bone in the middle is very dense and very tightly packed. If we compare that to the bone directly underneath it, that cortical bone around the outside has become very thin, so its ability to protect against those bending and twisting forces is going to be reduced. And the spongy bone on the outside is a lot less dense, and those small holes in there are quite a bit larger. Therefore, it's going to be more susceptible to compressive forces. So if that osteoporotic bone had quite a lot of force applied in various directions, its likelihood of fracture would be a lot higher than the bone above it.
So these are some common misconceptions. So one, osteoporosis isn't that common. There are actually over 6 million Australians who are diagnosed with osteopenia, and then over 1 million who are diagnosed with osteoporosis. So as Benjamin mentioned earlier, it is a silent condition. So these are just stats in relation to those who have been reported and diagnosed. Number two, osteoporosis doesn't affect men or young women. Unfortunately, it does. So males over the age of 60 years can affect 1 in 6 males. Alongside that, with younger females, whether it's early onset of menopause or other, conditions, health conditions, that can actually increase your likelihood. Whereas females over the age of 60 years old, there is 2 out of 3 females who will be diagnosed. So some common reasons why maybe young women may have low bone density might be breast cancer, going through certain medical treatments, eating disorders, thyroid disorders, autoimmune disorders as well, or whether they're taking particular medication as well. So also known as, corticosteroids. Number 3, if you have osteoporosis, it's too late to protect your bones from fractures. Again, it is reversible, so don't believe that you cannot improve it. You most definitely can if you are doing the right things with both, exercise, maybe diet, and again, if medication is applicable. Number 4, participating in walking and swimming is enough to prevent fractures. Unfortunately, they're not enough to build your bone up. So bone is a living tissue. You can actually build it, get it stronger as well to prevent fractures and breaks. So swimming and walking do not provide enough stimulating load to build your bones. And Ben will touch on that a little bit further. These are just some common risk factors. So we've got both genetic and lifestyle. So with genetic, depending on what gender you are, sometimes, your genes can influence that too. Could be calcium intake, could be exposure to vitamin D, could be age, body build as well. It could be, again, medical conditions such as celiac disease where you can't absorb the right, vitamins and calcium. Lifestyle-wise, hopefully we all have more control in relation to lifestyle factors, but that might be as simple as being sedentary, so not doing exercise, smoking, excessive alcohol intake, and actually recent research has suggested being overweight or being obese there are, I guess, hormones associated with a drop in your bone density. Whereas some others might have thought previously, having greater mass and weight through your joints and bones, you actually have a less likelihood of developing osteoporosis.
We've mentioned the term or the idea of fractures quite a few times already. This picture here depicts the 3 most common sites of osteoporotic fracture. So I've got the hip, most common in the femoral head of the hip. We've got the spinal fracture, so predominantly in the lumbar spine, so in the lower back, and in the wrist or the forearm. So these are the 3 sites that are of most concern or most prevalent of osteoporotic fractures. And these are the 3 sites that are tested if you are having a DEXA scan for diagnosis of osteoporosis. So I want to introduce you guys to a term called the fracture cascade. And what it simply means is your risk of a future fracture will increase with every new fracture that occurs. So research has shown that if a female experiences a spinal fracture, she's 4 times more likely to experience a second fracture within 12 months. So that's if a female experiences a spinal fracture, 4 times more likely to experience a second fracture within 12 months. That's quite significant. And as you can see from that graph, starting with a forearm fracture, they then had 3 vertebral fractures and then a hip fracture. And that's slowly increasing the morbidity and the disability associated with those fractures as well. So it's really something that we're really cautious on, is trying to prevent that first initial fracture from occurring, or if you already have that initial fracture, putting all the steps in place that we can to manage your bone health to prevent that second one down the track.
So that brings us to the diagnosis. So some of you, I guess, listening in may have completed a DEXA scan before. It is known as a dual energy X-ray absorptiometry. So what it is a scan that might take 10 to 15 minutes. Often they'll recommend taking off any jewelry or any accessories or anything like that. As you can see in the picture, you're lying down on your back, so it is one plane, and they're going to be scanning over the top of your body and back again. With the DEXA scan, it is the gold standard. So you're able to get this at, I guess, hospitals or radio therapy clinics. With the, I guess, referral method, your GP or allied health, depending on whether you're seeing an endocrinologist as well, they will refer you on to, I guess, for a DEXA scan. Your GP may also kind of assess you for any predisposing conditions, whether you have, again, early onset of menopause, whether you have particular medical conditions as well. Hopefully that'll prompt them to actually encourage you to go get a DEXA scan. Depending on your conditions and your medical history as well, sometimes Medicare, you can actually get a rebate back on that too. So the next question is how often to have a DEXA scan? Gold standard again, it's probably recommended on average every 2 years is the recommendation. By all means, if you are undergoing a certain, I guess, intervention, whether it's through exercise or whether it's through medication, they would hopefully recommend every year just to assess the effectiveness of that treatment plan. It is super important that when you do get your second or your follow-up DEXA scan, you do actually get it at the same facility on the exact same model as well. That's super important because each machine's calibrated differently. They might be different brands as well, so they will read differently. So that's super important to be able to compare your results.
Once you have your DEXA scan, you're going to get a report, or your doctor will show you a report that looks something like this. What we're really looking for, or what the biggest focus from this result is what we call the T-score. So the T-score is what's actually used to diagnose osteoporosis, and it compares your bone density to that of a healthy 30-year-old of the same sex. As Nicole went through earlier, around that 30 years of age is when you reach your peak bone mass. So you're comparing what your bone density is now to the gold standard of bone density. You may also see what's referred to as a Z-score on these reports as well. Now, this score is also used, but not quite as commonly. So what this score does is it compares your bone density to someone of your same age. And the first question I get a lot is, why don't I compare against someone my same age? And, you know, that's perfectly reasonable. But if we want to compare it to the gold standard of bone health, a lot of individuals having these scans are over the age of 50, 60, getting into their older stage of life. If we compare you against your similar age peers, most people that age have somewhat level of degeneration. So the results probably wouldn't be as reliable. Where this scan is most commonly utilized is if someone has had osteoporosis diagnosed secondary to another chronic disease or chronic illness, maybe earlier in life. Nicole mentioned earlier that celiac disease, for example, can lead to osteoporosis due to limiting calcium absorption in the body. Therefore, some in the 30s or 40s might get a diagnosis of osteoporosis. In that situation, we'll probably use the Z-score over the T-score. So what does a T-score actually mean? Well, you can probably get a number anywhere ranging from -4 to +4. As you can see there, anything from -1 and above is in that normal bone health range. Once you get between -1 and down to -2.4, so we classify as osteopenia. You may have heard that term before. It simply means you have low bone density. You are not yet classified as osteoporosis, but it is a caution to start thinking about some management and treatment strategies. And once you have that -2.5 as a T-score, that's when you're clinically diagnosed as having osteoporosis.
So that brings us to the bone remodeling cycle. So your bones are constantly rebuilding. So there's two, I guess, cells that we probably want to be aware of. What we call your osteoclasts. They break down your bone. So what we can see here on the top diagram, you've got the active osteoclasts in the purple, which actually, break down the bone. Then over time, with the reversal, we have our osteoblasts, which actually, form your bone or rebuild it. So there is the opportunity of actually getting stronger with your bones, which is obviously fantastic news, and hopefully that's something that, maybe some of you weren't aware of previously. The best way to explain this is actually through a bit of an analogy with bricklayers. So if we had, for example, the 3 bricklayers on the left-hand side were your osteoclasts. So they're taking a brick down or 1 brick down every time, whereas maybe the 2 on the right-hand side are considered your osteoblasts. So as you can see, they're placing 1 brick up at a time, working together. So what we can just, see from this picture and analogy is there is an imbalance between the bone being broken down and obviously the rebuilding of the bone as well. So our, idea is through the use of exercise, we're hoping to really stimulate, obviously, a greater activity of the osteoblast by hopefully loading up those common fracture sites through the use of isolated strength training.
All right, so I'm just going to touch briefly on nutrition. There's a few nutrients that are vital for your bone health. The first one we've already touched on is calcium. Its roles within the body are to build bones, to help with muscle contractions, so within the cell, and nerve signaling, so helping nerve signals travel around the body. As you all know, it's found in dairy and can also be found in supplementation. I would just a note to not just go out and start taking calcium supplements. Definitely have a blood test with your GP first and look at what your calcium levels are. If you're getting enough from your diet, then that's fine. Having additional calcium isn't going to give you additional benefit. There's only a certain level where you're going to get the most benefit and it can be absorbed. If you have more than that and keep supplementing, it's just going to be quite expensive, and it's not going to be of any added benefit to you. The factors that can affect the calcium absorption, number 1 is low vitamin D levels. So we know these two work really well together for our bone health. Excessive caffeine or alcohol intake, certain kinds of medical conditions, as I already touched on, such as celiac disease or kidney disease as well, and certain forms of medication. So if you are being prescribed a new form of medication, just double check with your doctor or specialist as to what the side effects may be in regards to your bone health. The second nutrient, as I just mentioned previously, was vitamin D. So its role within the body is to really assist with the absorption of calcium. As it says there, 30% of Australians are deficient in vitamin D. So especially through the winter months, it's really important to make sure we're getting as much vitamin D as we can. We all know it's found in sunlight and also oily fish. So again, don't go out eating 100 cans of tuna a day. Have a blood test, speak to your doctor, figure out how much you need to be having. Just a side note with the nutrition side of things, as exercise physiologists, we can give you general advice and recommendations in regards to nutrition, as I've just done. However, if you're wanting a specific individualized meal plan for yourself or for any chronic disease, that's when I would definitely recommend getting in touch with a dietitian, as they can set you up with the best plan specifically for you as an individual. If you are looking to get in touch with someone, Nicole and I can recommend anyone if we need to.
All right, so that brings us to, I guess, the medications. So like we've, I guess, previously mentioned, you've got these two cells, the osteoclasts, which break down the bone, and osteoblasts, which, I guess, form new bone. So the medications that you may currently be on or might be maybe prescribed down the track work to reduce the activity of the osteoclasts. So by hopefully reducing their activity, we can then see the osteoblasts, I guess the activity of that increase, and hopefully it's maximized. So having that imbalance of hopefully building up the bone, we can actually see, I guess, some changes. So the medications will work to improve your bone strength and reduce your bone loss. So this is super important as well. Making sure you seek medical advice first before doing anything anyway. But your endocrinologist will determine the most appropriate treatment to your situation. And they'll obviously consider any other medical conditions that you do have as well. So sometimes intervention-wise, some people might start, depending on severity of the bone density, might start with just exercise or might be a combination of exercise and medication.
Okay, time for the exercise component. This is the good stuff. I'm going to take you guys through the optimal bone loading exercise program for osteoporosis or for just building bone mineral density in general. So we're going to start with looking at this little circle diagram on the left of the screen. At the very top of there, we can see progressive resistance training. So such as the weight training we do at Keiser, really beneficial for your bones. You're putting an external load and pressure through your bone, but you're also strengthening the muscles and the structures surrounding the bone to provide it more strength and stability and enable it to absorb more force. The second type of exercise that's been shown to be really beneficial for bone mineral density is what we refer to as impact exercise. Now, we've sort of broken this down into two separate categories. You've got your low-level impact exercise, which we refer to as weight-bearing exercise. So this can be things as simple as climbing stairs, step-ups, or stomping your feet, just that low-level impact. And the other side of that is the high-level impact activities, which we call plyometric exercise. So this can refer to things such as jumping, hopping, skipping, or bounding. We know from the research that these forms of impact exercise are really beneficial for your bone health. It is frustrating, though, I guess, that those who are diagnosed with osteoporosis are generally older and may have other comorbidities or other injuries that will limit their ability to do certain forms of impact exercise. That's why it's really important that you see someone who makes up that optimal program for you and starts you at that lower end and gradually progresses as your tolerance improves. But if we're talking about impact exercise, there's a term we like to use called osteogenic capacity, which simply means the ability to promote bone growth or the ability to assist with bone growth. This little table on the right outlines various common sporting activities and what is their effect on bone. So the really highly osteogenic sports, as you can see there, basketball, netball, aerobics, dancing or gymnastics, tennis, and sort of skipping, all have a lot of impact. It's really beneficial specifically for bone growth. If you look at the other end of the spectrum, activities like walking, swimming, and cycling, although they are fantastic forms of exercise that improve cardiovascular fitness and muscular endurance, they have very little or limited effect directly on your bone health and increasing your bone density. So it's really important that if you're thinking about getting started with an exercise program for your bone health, that you're including the most important modes of exercise. The fourth type of exercise we have on there is balance. So Nicole and I have talked a lot about fractures. And I guess what's really promising is that fractures can be largely preventable through the right type of exercise. And we know that your balance does decline naturally with age as you get older. But there are exercises and certain forms of balance training you can do to improve your balance and prevent falls long term, which we'll go into in a moment. So we're going to start with going into progressive resistance training. So for those of you that like a definition, it is a method of increasing the strength of a weak or injured muscle by gradually increasing the resistance against which the force works, such as by using graduated weights. Now, that's quite a mouthful. I think the most important thing to take away from that sentence is the word graduated weights. It's really, like, anyone can just lift a weight and do that same weight forever. What's really important is that we are progressively overloading and progressively increasing our load we're putting on the bone. Because once that muscle, that bone gets used to that same stimulus every time, it's not going to lead to any further adaptations. It's going to stay the same. So you need to be continually providing a new stimulus so you can then adapt to that and continue to improve. This can be completed using machine-based training such as we do at Keiza. You can also use free weights and even your own body weight. What are some of the benefits? Increased muscle mass, increased muscle strength, reduction in visceral fat. Visceral fat is the fat that actually sits inside your abdominal cavity and surrounds your organs. So you can't actually see it from the outside. Improvement in bone mineral density. It actually can also improve your cardiometabolic markers, so blood pressure, blood glucose, cholesterol, etc. And it can help to reduce joint pain, wear and tear, such as arthritis pain, things like that. So how much should we be doing? The Australian Activity Guidelines recommend 2 strength training sessions per week, and we 100% agree with that. You can progress to 3 as you become more of an experienced exercise with strength training, but there's no need to start with 3, start with 2. We don't recommend doing 1 a week because that's not really frequent enough to provide that stimulus enough to get the long-term adaptations that we're after. We want to be targeting all major muscle groups, especially those that surround the common osteoporosis fracture sites. So surrounding the lumbar spine, surrounding the hip, and surrounding the forearm and the wrist. Intensity can range from low to high depending on your exercise experience and where your baseline levels of strength are. We do know from the research that the higher the intensity, the greater benefit you get. But what's really important is that we have that graduated approach and we start low and we slowly build you towards that higher intensity when appropriate. Sessions can range from 30 to 60 minutes. We know that 30 minutes is an adequate amount of time to get enough benefit from the strength training. And I think what's really important is that you touch base with an exercise physiologist to get the most appropriate program made up for you. Because when it comes to weight training for bone health, there are certain movements or there are certain exercises that are actually going to be contraindicated or not be recommended for osteoporosis due to risks. So it's really important that you have a program up for you by a professional.
So the next category is the, weight-bearing exercises. So definition-wise is forced to work against gravity. So some common examples would be just walking, hiking, jogging, climbing stairs, playing tennis and dancing. So it's probably hopefully something that you do already in your everyday activities. But again, this is probably more the lower intensity exercises that will help to build a bit of bone loading. But like Ben said, it is super important that we complement it with some plyometric and impact exercises. So these exercises here are where the muscles exert maximal force within a short period of time, stretching of the muscle before immediate contraction. So as you can see, pictured here in the middle, we've got a lady doing hopscotch. So some exercises will be hopping, jumping, skipping, star jumps, any kind of movement that is a forceful movement and I guess generating that power as well. This won't be, prescribed to everyone, depending on, again, how knees, hips, etc. pull up, or maybe a bit of medical history prior. So that's really important that that is assessed before. Progression-wise, It's really important that you are progressing it, very much the same as Ben mentioned then. Start low and then slowly build up as well to ensure that we are overloading the bones and the muscles too. Some examples might be, I guess, changing up the difficulty of it. It might be jumping from a height. It might be jumping from a different angle as well. So that is really important to ensure that we're continually challenging the bones and the muscles. So I think research has just demonstrated as well, yeah, a good starting place might be doing about 3 sets of 10 repetitions of just basic jumping, just straight up and down, not aiming for any height or anything like that. That could be a good starting point.
The fourth mode of exercise I mentioned previously was balance training. So we're going to quickly touch on falls because the main focus of balance training is falls prevention. So a fall is an unexpected event in which the participant comes to rest on the ground or a lower level. Over 1/3 of Australians aged over 65 fall 1 or more times every year. And this can have quite severe consequences, from minor injuries to hospitalizations, hip fractures, permanent disabilities, and even death in extreme circumstances. They actually have an extreme burden on the health system. So you can be looking at anywhere from $1,600 to over $5,000 per fall. So if we've got over 1/3 of Australians falling more than one time a year, there is quite a big burden on the health system. And I guess what's really positive is that it can be prevented through exercise. But what's really important to note is there has to be the right dose of exercise and the right modes of exercise. And we can predict someone's risk of falling. We can do this by assessing their lower limb muscular strength. We can do it by assessing their walking patterns or their gait, how they're moving, and then looking at their balance specifically. So, for example, how long can you stand on one leg for is a really good quick test of your balance. So when we're going to be training balance, there's different components that contribute towards balance. It's not just balance itself. Number one is strength. You need to have the strength in the muscles to be able to balance. Number two is power. So not only do you need to have the force, not only do you need to only be able to produce the force, such as strength, you need to be able to produce that force quickly. So if you're going to be having a fall, you want to be able to catch yourself and be able to produce that force fast enough. Number three is coordination. So you want to be able to use your limbs freely in space and coordinate them to each other. Number four is stability. We need to have stability around the joints and to help it to protect against other external forces. Number five is reaction time. So how quickly can you respond to a certain stimulus? And the sixth one, probably one of the most important ones, is confidence. You need to have belief in your own ability to do a task. If you're not very confident at walking upstairs, for example, you're going to find it hard before you even try. So by building up those other 5 forms of balance, your confidence should improve as well. So when we're looking at balance training, in order to get a significant improvement in balance, we need to be doing a minimum of 2.5 hours per week made up of those 6 balance components. So your strength training comes into that. If you're training twice a week for half an hour, that's 1 hour gone. We still need to have a minimum another 1.5 hours of other forms of balance exercise. With balance exercise, sorry, Nicole. Nicole's demonstrating a couple of different movements there. So on the left of the screen, you can see Nicole doing a single leg balance exercise. That's what we call static balance. So it's done in a stationary position. Other forms of balance you can see on the right, she's doing an arabesque, which is she's moving forward and back. So it's referred to as dynamic balance. So there's different forms of exercises that we can utilize to get the same benefit. Alrighty, so what we do, I guess, at Keyser, if you're currently a member or maybe never heard of us or you're being recommended to us. So we've got qualified, experienced exercise physiologists with science-based approach. Efficiency of the strength training. So again, starting with 2 sessions per week can take up to around about 30 to 40 minutes.
So a very efficient and effective way of training. Don't worry, you won't be spending more than hours and hours at the gym. Bone loading training. So we've actually got a break-free program, which we'll touch on next. The programs are individualized and tailored around your capabilities and obviously medical history as well, what you're currently doing, what you have done in the past, but also tailored around what your particular goals are. We've got high quality machines that are safe, risk-free training and adapted to all ages and goals. So on the machines, if you haven't already been on one or a member, every individual has their own settings. So again, myself and Ben would have completely different setups on each machine. So it is very individualized and a safe way of doing it. It is working on the machines as well. So there's no free weights or anything flying around. So with the increases of the weights, with progressions, there's a minimal increase of about 2 pounds. So I think that is around about 1 kilo. So you can go quite slowly with the progressions. Muscle isolation. So we're able to work on posture, balance muscles, and obviously injury prevention alongside targeting those common fracture sites. So I think the next page will have a few pictures. So top left-hand corner is our lumbar extensor. So that's going to be helping to target those deeper muscles, multifidus, erector spinae as well, around that lumbar region. Again, very much important. It is contraindicated to go into too far flexion or extension. Once an exercise physiologist has a review of your DEXA scan, where your T-scores are, etc., we can then set you up appropriate with the safe range of motion. The one on the right-hand side, top, is our leg press. So as you can see, I guess the gentleman in the photo, you're pressing your legs out, pushing through the heels. This is a super important one for loading up what we call that neck of femur, right up into the hip, which often is, I guess, a common fracture site. So for this one, what we can do is we can actually alternate what position the backrest is at, and that'll actually determine the load of, or the angle of load. The one on the left-hand corner, bottom left-hand corner, is our abductor machine, so working our gluteus medius. The one in the middle, we've got a few hand and wrist exercises, and the one on the bottom right is our chest press, so loading up through the wrists. That brings us to, I guess, the two group classes that we do run at most, I guess, clinics. So we've got a break-free class, which is the bone health group class. So with this class, it's an individualized exercise class designed to safely load your bones at common fracture sites, with the primary focus of improving your bone mineral density, hopefully with improvement, otherwise management. And it is only open to those who are diagnosed with either osteoporosis or osteopenia. The alternative program is what we call stable and able. So this one is a balanced group class. So it's a combination of functional strength, power, and balance exercises for those who are wanting to reduce the risk of falls, improve their hip, knee, ankle stability, or sporting performance. So if you're a keen skier or snowboarder or anything like that, yeah, obviously get in touch with us if you'd like to attend any of those classes. They're a nice social way of doing it. As we kind of discussed earlier too, we are back doing them face-to-face at a limited capacity, but fingers crossed in 2021, we'll have a few more classes up and running. So that brings us to, I guess, a bit of a special. So a big thank you for obviously joining in, myself and Ben. Hopefully you've learned something from today. We'll obviously go through questions coming up next, but this offer is for you guys who have attended today. So the 121 of you, if you haven't already seen an exercise physiologist, we are offering a half price initial assessment. So yeah, I guess the cost would be $54.50, where it usually costs $109. During that initial assessment, we sit down, we have a chat about everything, discuss what's going on, medical history, have a chat about your goals, and we would like to actually go through a few exercise and baseline measures that will be, I guess, assessing your strength, balance-wise too. Then from that assessment, we can then create you with the best plan moving forward. So these are the centres, or clinics I should say, that do have exercise physiologists at the moment. So hopefully there is one close by to you. Otherwise, obviously, Ben and myself are more than happy to see you guys if you're happy to travel, depending on where you're based. So yeah, our email addresses are there if you have any further questions or anything like that. But I might throw to Katie. Hopefully Katie's on with a few.
Yeah, awesome. Thanks so much, guys. That was awesome. I've got a heap of questions here, so we'll get straight into it. So I've got a question here from Catherine. So she's got, I have osteo in the lower spine. I've been advised not to bend from the waist without bending the knees first. Is this correct? And what exercises should someone with osteo in the lower spine and hip do so to not aggravate the condition?
I can take that question. I think, yeah, as Nicole mentioned, going too far forward into trunk flexion can be contraindicated. Some research has shown that loading the spine in heavy flexion can increase the risk of fracture, but it is very individualized. I would highly recommend bending the knees first, because then you're going to be utilizing your muscles around your hips and your legs to complete the movement rather than putting all that load to your lower back. In terms of what exercises can be best with someone with osteo in the lower spine, Nicole mentioned it before, a great example is our F3.1 machine upstairs, because we're able to safely load the muscles and the vertebrae in that lumbar spine and really focus on that bone density.
Awesome. Thanks so much for that, Ben. I've got a question here from Barbara. Does muscle loss equate to bone loss?
No. So unfortunately, they don't work hand in hand. Obviously, when you get a DEXA scan, they actually give you a bit of a body composition as well of what your lean mass is, but also obviously your bone mineral density as well. So I guess over time, we do know that both unfortunately decline, but they do decline at different rates as well. So that's going to be very dependent on what you have done in the past through exercise-wise, but also what you're currently doing. And then again, how you plan to progress those exercises further. So there isn't a direct link between bone density and muscle loss, or losing them. So they can be at different rates, but your goal will be to improve both. Just in general.
Great. We've got another question here from Jane. What causes muscle wasting?
Well, it can be a number of things, but unfortunately, there's a term called sarcopenia, which refers to muscle loss associated with aging. So as you get older, if you're not doing any form of strength training, your muscles will just start to waste with age. If you are inactive, that process will be fast-tracked. So it's really important that we are being as active as possible, as early on as possible.
Great. Got another question here. Why does the fracture occur? Does one lead to another, or is the same underlying cause to blame for all of them?
I guess that's in relation to the fracture cascade. I guess in general, it's probably just an indication of your bone density health. So the more severe it is, obviously the likelihood of having that additional or further fracture down the track. I'd probably say falls can really occur at any time. They probably occur when you least expect them as well. So I think just in relation to the exercise-wise, as long as you're covering a bit of balance-wise, those kind of components that we covered previously, we can hopefully prevent falls from occurring, therefore preventing fractures too. But strength around those particular areas can also be, I guess, a considered factor that might increase your risk of having that further fracture. There's just so many factors that can contribute to it. Unfortunately, there's not just one particular thing that we can kind of pin down and say, this is a reason.
Great. And we've got another question here from Jane. Is a spinal fracture the same as a herniated lumbar disc?
It is not. So that's a separate injury. So if you've got two vertebrae in your back, the disc actually sits in between them. So when the disc is herniated, that's completely separate from the actual vertebrae themselves. The fracture occurs in the bone and the disc occurs in between the two bones. So they're separate structures.
Great. We've got another question just from an anonymous name. Does the T and Z score take into account different ethnicity variations?
Ooh. I actually don't know about that.
Yeah, I've been unaware that it has, but I'm not sure. Sorry, well, we can definitely look into that for you if you like.
Yeah, if you're happy to leave your email address, whoever asked that question, more than happy to look into it.
Awesome. Thanks, guys. I've got another question. Is 500 to 600 milligrams of calcium elemental calcium?
Unsure.
I reckon that's the same person that stumped you again.
I'm not too sure either, to be honest. That's probably more of a question for a dietitian or a nutrition specialist.
Yeah, apologies. Out of our scope a little bit.
Awesome. So Anne was wondering, will this special offer that you mentioned before be available for Mornington when it opens in 2021?
I would say yes, most definitely, but I'm not 100% sure whether there'll be an exercise physiologist down in Mornington. So it's entirely up to you if you're wanting to see, again, either myself or Ben or someone up in Melbourne. And then if you plan to train at Mornington, there'll be the exact same machines as well. I'm not sure if they've actually hired an exercise physiologist just yet. Hopefully that's a good question, Anne.
I've got a question from Jackie, who can't do a strength test because she has osteopenia, and she's finding it a bit disappointing because she'd love to be able to see her measuring of improvement over the year. Is there a point in which strength testing may be able to occur?
Yeah, so unfortunately, the type of strength testing that is traditionally done on the keys and machines is what we call isometric strength tests, which is when you're pushing against a static force as hard as you can. Now, from the research, really high intensity isometric contractions have been found to be contraindicated for osteoporosis or osteopenia because it actually puts you at a high risk of a fracture. So we're just being cautious and just saying let's avoid those for those that have lower bone density. There's definitely other forms of strength testing that can be done. We can do other forms of strength tests that don't involve the isometric contraction, whether it's a test based on how many repetitions you could do at a certain weight. If you speak to the exercise physiologist in your centre or closest to you, they can definitely set you up with some different form of strength tests and balance tests to monitor progress that don't involve that static isometric hold.
Awesome. We've got a couple of questions here too from Barbara and Heather about the Break Free program. Could you go into a little bit more detail about that and where they can access those programs?
So it's not like an online program or something that we send out. It is in clinic. So the idea is if this is something that you'd like to attend, is you all go through an initial assessment where we go through, I guess, a list or an array of different exercise tests. Then from that, we can then create your individualized program. So again, it'll cover those exercise components that are included in the optimal bone loading program. Again, depending on what your capabilities are, I don't know, just an example, it might be a few sit to stands or squats, it might be a few step ups, it could be balance work, whether it's on a bit of an unstable surface, or whether it's skipping, boxing. Depending on your capabilities, we'll just make sure it's more, I guess, a bit more functional, where we're targeting those areas as well. So yeah, I don't know, Ben, if you want to add anything else in, that's probably goes to the initial step. And then with the group classes, depending on the clinic you attend, the space that we've got, for example, Melbourne, we've got a maximum capacity of 4, participants per class. It's a 45-minute session. You come on in, you do your exercise, being supervised as well.
Awesome. Thanks so much for that, Nicole. We've got a question here from Jane. Can your porous bones increase in density with strength training?
Yeah, absolutely. So I mentioned that a few times throughout the test. They definitely can see an improvement in bone density. I think what's really important to note, though, is that osteoporosis is a progressive condition. So by that, it means it does progress over time. So the main focus of any treatment modality is to maintain what you have and avoid any further progression. And if you do that, that's an absolute win already. And it can go back the other way. In some individuals it does, and some it doesn't. They still think there's some genetic factors at play, but if you're doing the right modes of exercise, you're consulting all the right specialists, you're going to give yourself every chance to see an improvement in the right direction.
Fantastic. We've got another question here from Chris. Does vitamin D3 help or prevent osteoporosis?
Unsure through, what I guess dosages, etc. I guess what we do know and what I can say is obviously being exposed to, I guess, a greater amount of vitamin D can hopefully influence your bone density at your peak bone mass. But again, unfortunately, I don't have a specific answer for that. Apologies.
Awesome. Well, that might be all the questions that we get through today, and we'll just wrap it up there. If you do have any further questions for the guys, feel free to contact them via their email address. They're more than happy to answer any questions at all. And this session has also been recorded and will be emailed out to you guys for a link. So if you want to watch it back or share it with any friends and family, you can definitely do that at a later date. But thank you so much, Nicole and Ben, for taking us through it today.
No worries.
All right, our pleasure. Thanks for attending, guys.
Again, any questions, feel free to chat to Ben and I via email, or we can get in contact with you guys.
Amazing. Thanks, guys.
Thanks, everyone. Have a good arvo.